Good afternoon, ladies and gentlemen. I'm Tang from the School of Pharmacy, Monash University, Malaysia. I'll be the host for today's symposium on cardiovascular research. This talk will last for about 15 minutes, followed by 5 minutes Q&A. If you have any questions pertaining to the talk, please type your questions in the Q&A box. Our speaker will either reply back to you via text in the Q&A window or answer your questions live during the Q&A session. We are honored today to have Dr. Satirah Zainalabidin as a speaker for this session. Dr. Satirah obtained her undergraduate and master's degree from Universiti Kebangsaan, Malaysia, and a PhD from the University of Glasgow in the United Kingdom in 2011. She is currently an associate professor at the Faculty of Health Sciences, Universiti Kebangsaan, Malaysia. Dr. Satirah is an expert in cardiovascular physiology and pharmacology. Her main research interest focuses on understanding the mechanisms of cardiac remodeling in different animal models, such as myocardial infarction, heart failure, and high-fat diet rats. She has been involved in several therapeutic studies on medicinal plants like roselle, as well as single compounds like S-L-cysteine. Over the past few years, she has received grants such as FRGS, NRGS, and Malaysia Torre Science Foundation as principal investigator. She has also has collaboration at the international level with Baker Heart and Diabetes Australia and the University of Glasgow. Today, she's going to talk about one of her active research area, that is the action of S-L-cysteine on cardiac remodeling in myocardial injury. Dr. Satirah, the stage is yours.
Assalamualaikum and a very good day to everyone. Thank you for having me today to give a talk. So the title of my talk is The Action of S-L-cysteine or SAC on Cardiac Remodeling in Myocardial Injury. Now, cardiovascular disease is the world's biggest killer, where it has caused 23.4% of total deaths, and this is projected to further increase by the year 2025. In Malaysia, ischemic heart disease was found as the first principal cause of death in 2019. Now, ischemic heart disease, or also called as coronary heart disease, is the term given to heart problems due to atherosclerosis or constriction of blood vessel. Now, when the blood flow to the heart muscle is completely blocked, the heart muscle cells die, which is termed as myocardial infarction or heart attack. Now, cardiac remodeling term was aimed to characterize the replacement of infarcted tissue with scar tissue, particularly within the left ventricle. Among the hallmark of cardiac remodeling is cardiomyocyte necrosis that lead to the release of cardiac injury marker such as LDH, troponin T, and troponin I, as well as CKNB. And then there's hypertrophy, fibrosis, as well as inflammatory infiltrate that results in progressive loss of ventricular function. And eventually, this will evolve to the signs and symptoms of heart dysfunction, or better known as heart failure. So it is well known that natural products contain high therapeutic and high antioxidant properties, such as garlic. Now, in garlic, especially in aged garlic, okay, there is an abundant compound that is called as S-L-cysteine, or SSC. So it is a type of organosulfur compound, and it is especially high in an aging garlic. So when it is taken orally, okay, it is rapidly absorbed by GIT, and the bioavailability is almost 100%. SST has been found to have a broad protective properties such as anti-cancer, anti-inflammatory agent, antioxidant, and anti-diabetic. In addition, this compound has also been proven to be cardioprotective in vitro and vascular model. However, there is still scarce studies, okay, to study its effect in vivo cardiovascular model, which led us to ask the question, can SSC improve or limit cardiac remodeling after myocardial infarction in a clinically relevant setting? To answer this question, we divided the experiment into two phases, which is the ex vivo and in vivo. So for the first phase, the aim was to study the impact of direct SSD to the cardiac function, antioxidant status, and mitochondrial permeability after ischemia reperfusion. Now this is a setup, okay, for the ischemia reperfusion experiment where we use Legendorf setup. So the rat's heart would be excised and mounted on the cannula, and the heart would be mounted, okay, on the cannula and perfused with physiological saline. And into the left ventricle, we have inserted a latex balloon, okay, as a pressure sensor, okay, to sense on the changes of the left ventricular mechanical function. So this is the study design for the IR protocol. So here is a typical tracing on the left chart that shows this is during the stabilization, and this is during the ischemia for 35 minutes, okay, according to our protocol. And this is during the reperfusion, okay, where the heart would regain its contractility. So in this study design, okay, we have divided into sham, IR, and then we have given a direct administration of SSC to the heart. So the results have shown interesting findings. Okay, so LDH, okay, which is a cardiac injury marker, was significantly reduced, okay, delayed and reduced after SSC administration. Okay, so LDH is a very good indicator, okay, in showing the extent of the injury and predictor of the pathological changes after ischemia. And SSC was shown to be able to delay and improve, okay, the injury condition. Now next, we tested on the SSC on MPTP opening. So MPTP, or mitochondrial permeability transition pore opening, is a crucial and lethal event that occurs during IR injury. So a prolonged MPTP opening results in mitochondrial energetic dysfunction, organelle swelling, and necrotic cell death. So here you can see in this diagram, okay, this is during the physiological and this is during the pathophysiological, okay, over MPTP opening, right? So this assay was conducted to determine whether SSC possesses the ability to prevent MPTP opening in the cardiac mitochondria. So cyclosporin A or CSA, okay, was used to block the MPTP, okay, by binding to the cyclophilin D and attenuate the calcium-induced MPTP opening. So our experiment has shown that SAC significantly prevent the MPTP opening. Now, this result is from the Legendorf experiment. So this is a typical lab chart tracing, okay, where simultaneous parameters are being recorded, okay, during the experiment. And our results have found that SAC was able to recover the cardiac function after the ischemic insult. Okay, so the parameters that were measured were left ventricular developed pressure, systolic pressure, and diastolic pressure. This is an indicator for systolic, okay, systolic marker and diastolic marker. And finally, the coronary flow recovery. And SAC has shown that it could improve all these uh, parameters, okay, up to the IR condition. Now next, since SAC is a very potent antioxidant, so we investigated, okay, the potential of SAC in the glutathione metabolism. So this is the result for glutathione. So glutathione is a natural and endogenous antioxidant enzyme that is involved in quenching electrophilic substances, for example, like hydrogen peroxide. And the result has shown that SAC was able, okay, to increase the antioxidant enzyme. So the conclusion from this phase was that SAC was able to recover the post-ischemic cardiac function, improve the glutathione metabolism, and preserve the mitochondrial function. Now next, would we see the same similar effect in vivo model? So in this phase, we aim to study the impact of SAC given after myocardial infarction and look into the cardiac remodeling characterized by hypertrophy and fibrosis in rats. Now, this is the study design of the experiment where we use a Vista rats and we induce myocardial infarction or MI with isofenilin, which is a beta agonist drug, twice. And then after that, we gave SAC at the dose of 50 or 100 mg per kg orally for 7 days. And the results have shown very interesting results. Okay, SAC was able to attenuate cardiac hypertrophy. So based on the hematoxylin eosin staining, okay, from here we can see the enlarged hypertrophy in MI compared to the sham. And when quantified, okay, we could confirm that SAC treatment was able to reduce the hypertrophy. And this was further confirmed by the gene expression for hypertrophy marker, which is ANP and BNP. The next, SAC was found to limit cardiac fibrosis based on the pre-series red staining. Here, as we can see, so this type of staining would stain collagen as red color. And when quantified, okay, it shows a very marked, okay, high deposition of collagen. And SAC was able to reduce the fibrosis area. And this was again further confirmed through gene expression by the fibrosis markers, which are collagen 3 and fibronectin. Then we looked into the antioxidant oxidative stress. So from the immunohistochemistry result, okay, we looked into the nitrotyrosine. Okay, so here you can see that the nitrotyrosine is very significant, okay, indicator of oxidative stress. Okay, and SAC was able to reduce this, and the gene expression for NOX2 had further confirmed this result. SAC was also shown to improve, okay, the antioxidant status by the GSH and the glutathione reductase level, okay, similar to the ex vivo result. And then we looked into the ACE81 pathway. Now, ACE enzyme, or the angiotensin converting enzyme, would convert in H1 into H2, and then H2 can bind to AT1 receptor and AT2 receptor. So we know that AT1 receptor activation can cause a lot of injury, okay, especially within the cardiovascular system. So when we measured the gene expression, and we found that SAC was able to reduce the ACE and also AT1 gene expression in the heart. So conclusion from this study is that SAC given orally for 7 days after myocardial infarction was able to limit the cardiac hypertrophy, fibrosis, and oxidative stress, at least in part by regulating ACE81. Now, to put in a nutshell, okay, myocardial infarction could cause oxidative stress, okay, hypertrophy characterized by ANP and BNP. So these are called as the fetal gene program. And then also fibrosis by increase of extracellular matrix and the neurohumoral factors. Okay, for example, ACE81. And this would cause a cardiac remodeling characterized by fibrosis and hypertrophy. And SAC was able to at least limit or prevent the cardiac remodeling from happening. Now, acknowledgement to the team. Okay, these are the postgraduate students, okay, who have helped, okay, throughout this study, and collaborators and the technical support, and for the funding and training. Okay, thank you to UKM Internal Funding, to FRGS, and for the student training in Baker Heart and Diabetes Institute in Melbourne. With that, I end my session, and thank you for listening.
All right, thank you, Dr. Satirah, for your wonderful presentation. Now I would like to open the floor to questions. Any questions from the audience? You may raise your hand. All right. Oh, by the way, Dr. Satirah, I have one question for you. I just wonder how this S-L-cysteine enter the cell. What are the mechanisms?
Okay, great. Thank you for your question, Dr. Tang. So actually, SAC, it could, we hypothesize that the action is through the metabolism of, it could activate this thionine gamma enzyme that releases a hydrogen sulfide gas. Okay, so it's a endogenous gas, okay, H2S. So we believe that SAC activates this H2S gas, and that is the one that gives protects the heart from further damage, okay, in cardiac remodeling.
I see. Another, I think we've got one question here from Amelia. She asks, how can this research transfer to clinical setting?
All right, thank you for the question. So we are looking at the possibility of applying this, like in the cases of myocardial infarction, okay, we would give it as an adjunctive treatment, okay, to MI patients, okay, after the incidents, so that we could prevent, okay, or at least limit from recurrent myocardial infarction. Okay, as we know that MI there's tendency for recurrence to happen. So we are hoping that SAC can be one supplement, okay, to be given to the patients. And actually, going back to your question just now, so that is the pathway that we are looking into at the moment, that whether it goes through the CSE and H2S pathway. So we're still looking into what's the relation. We know that it has antioxidant property, and how does that relate to the H2S?
I see. Oh, I have one last question for you, Dr. Satirah. So because I noticed from your slides, you use up to about 50 millimolar concentration for in vitro study and up to about 100 milligram per kg for the in vivo studies. Certainly, if you use a higher concentration, do you expect that this compound is toxic to the cell?
It's still safe. Sorry, I cannot remember the exact dose, but we have checked based on previous literature, and it's still way below the toxic range. So I cannot remember the number right now.
All right. Okay, I guess that's all I have for you. Since we do not have any further questions from the audience, and now it's almost 2:50, I think we should come to the conclusion. So on behalf of the organizer, I would like to thank Associate Professor Dr. Satirah for your time in sharing your wonderful work. I would like to invite Dr. Satirah to have a photo session with us.
Thank you for having me this afternoon.
Okay, hold on, Dr. Satirah and Dr. Tang. I'll take a photo. Okay, 1, 2, 3, smile. Okay, all done. Thank you.
Okay, thank you, Dr. Shafiq.
Thank you.
All right, so I would like to thank all the participants from joining us today. So I believe we would not end this session, right? We will just continue. So you may stay on for the subsequent session. All right, thank you.